So as we get started for the next part of our presentation today, I want to introduce to you Dr. Robert Brennan. He's an infectious disease specialist with the Infectious Diseases Associates of Central Virginia and works out of Lynchburg. He is board certified in infectious disease and internal medicine, specializing in treating HIV and hepatitis C. He got his education at the not too far down the road, University of Virginia, well, I guess a little bit far down the road, University of Virginia in Charlottesville, and then did his internship and residency at the Johns Hopkins Hospital Internal Medicine in Baltimore, Maryland. By the way, for those of you that ever use me for a resource for any of the STIs, the Johns Hopkins experts are the ones that we check in with if I don't know the answer. So he also then did his fellowship at Duke University. And we are so pleased that VDH has been able to work with Dr. Brennan with the AIDS Drug Assistance Program Advisory Council. He's also the co-medical director of the Ryan White Grant from Central Health. For those of you who may not be aware, Ryan White is a federal program that helps people that have HIV who are either underinsured or uninsured to receive their care, their treatment, as well as additional services. And he's also the vice president of medical affairs for the Coalition for HIV Awareness and Prevention. So it is my great pleasure to introduce to you Dr. Robert Brennan.
Thank you very much. Good morning. Make sure we're still the morning. Nice to see you all. Thanks for being here, and thanks to the Department of Health inviting me to participate. In particular, I want to thank Jenny Calhoun for working on my slides and making them look so good. They're much better than I started with, so thank you very much. I did bring a prop with me today, which is my stethoscope. And the reason I brought that with me is because several years ago, I was having lunch with a gentleman in our town who is a race director for all our community races. And I was coming from the hospital. I walked through with my stethoscope still around my neck because I had forgotten. And when I sat down, he said, you know, whenever someone walks into a room with a stethoscope or with a clipboard, like he does the race director, there's this air of authority when they walk in the room, that they really know what they're doing. And I think in my case, if you throw a little gray hair into it, the stethoscope and the gray hair help. And the reason I brought that is because I want to say up front, for full disclosure, I've only seen one case of monkeypox so far in this pandemic. So a lot of my references are going to be from other areas, but I know that I have Dr. Lee and Dr. Buffo-Boni here to correct me and keep me in line if I say anything that's a miscommunication. So thank you all for being here, and we'll go on. We're going to overlap a little bit, but you know, this is such an important topic, and epidemiology and transmission has a lot to do with treatment. So we're going to go over that a little bit. But I want to say, just to begin with, that we're talking about monkeypox, but we're also talking about smallpox, because as Dr. Lee has pointed out, they're in the same family. They're in the same area of viruses. And as we're going to talk about, and you've heard some already, the clinical picture, and specifically the diagnosis and the treatment and the vaccination for monkeypox is so similar to smallpox. So remember, as we talk about this, those two are going to be going hand in hand. Okay, there we go. So because of my little contact with patients that have monkeypox, I borrowed some slides from Dr. David Wheeler, who gave a similar presentation in Northern Virginia. And he's an infectious disease physician there, so I borrowed some of his slides, which we'll go through, but some of those are explicit images. Not to reiterate what's been said, but just to kind of talk about this one more time, because as someone who's been involved with infectious disease for a long time, the history of things really are always interesting to me. And relatively, it's interesting to know that in the 1950s is when this virus was first identified in animals. And it wasn't until the 70s there actually was a human case. So for 20 years, we thought that this was only in animals and not transmittable to humans. And then we found that it was. And then, as Dr. Lee has pointed out, in 2003 is when there was the first outbreak in the United States from prairie dogs that had been in a kennel with animals that had come from areas of infection from Ghana in Africa. Was worth keeping a note, which was also mentioned, but I think probably plays a pretty significant role in this, is the reason that Africa, Central and Western Africa areas that are involved with monkeypox is because in the late 1980s, monkeypox was eradicated from those areas, and a very strong brisk vaccination program for smallpox that was in that area was stopped. And there was significant concern because monkeypox was endemic that there would be an increase because as have heard already, that the smallpox vaccine is going to protect people from getting monkeypox. And in fact, that's what happened. That as time went on, they're seeing more cases, and it has already been pointed out, the number of cases being seen in Central West Africa are currently continue to increase. What's important to note also is that those cases that we're seeing, as mentioned, were clad 1 as compared to clad 2, and they were more virulent, they were more transmittable, and interestingly, in Africa, they were seen in young people, they were seen in children, they were seen in people who live in the forest, because they were being exposed to these animals that probably had the virus and was passing it on to them, as compared to our current pandemic, which is a much different demographics. So talking about transmission, we've gone through this before. We'll just be briefly that on the left-hand side of the slide, it shows that animals are the reservoir for this, or animals are the vectors. I'm sorry, we don't know where the reservoir. We think it's probably in rodents, but we don't know that for sure. But the vectors are different animals. We've talked about the prairie dogs. Obviously, monkeys can have it and can pass each other, and it can be passed to humans either directly through hunting for animals in Africa or someplace else and being exposed to their blood or being bitten by the animals, or by eating the meat, which is also can happen in Central West Africa where the meat is not cooked properly, what they call bush meat, be transmitted that way. So 2 ways to transmit it from animals to humans. As been said, it could be spread in our area through respiratory droplets. We haven't talked about vertical transmission, but unfortunately it can be transmitted from a pregnant woman to her child in utero. There's not a lot of data about that, but we know it can happen. We don't know what the incidence is because the numbers are so small, but that can also occur. And then it, as has been said, it can be passed in from fomites, so it can be transmitted just by contacting contaminated items such as linens or sheets or bedclothes. And then obviously we've talked about sexual behavior, which is clearly a major means of transmission for the infection currently. So just to talk about the clinical features, the incubation period is somewhere between 7 and 14 days from the time of exposure to the time where you're going to develop either symptoms or the rash will be 1 to 2 weeks. Most individuals, and particularly in the classic form of monkeypox from clade 1, that most of them will have a prodrome of that lasts about 3 to 4 days before they develop the rash. And that consists of a flu-like syndrome with fever, headache, and what's interesting about this disease compared to other similar diseases like smallpox is they develop localized lymphadenopathy. That's very characteristic of this infection. What's been found in the current pandemic with clade 2 in the United States and in Europe is that the incidence of prodrome is much less. So people can be asymptomatic until they develop a rash. And part of the problem with that is they're not having any symptoms. They're more likely to transmit the infection when they're asymptomatic. So clearly that can occur and does occur before the rash occurs. Then obviously they go on to the rash phase, which is 14 to 28 days after exposure. Most of the time the rash is self-limited, particularly with clade 2, resolves on its own. And the mortality rate for clade 2B, which we're seeing in this pandemic, is very low, like less than 0.2% as compared to clade 1 in Africa and Western and Central Africa, where again, it was younger children, people healthier, but the mortality is more like 10 to 13% in that group. So thank goodness that that's not as big a problem with this pandemic. The rash is the thing that's most predominant and is the most characteristic feature that will probably identify this as monkeypox. It's usually located on the hands, feet, chest, mouth, or near the genitalia or the anus. One of the comparisons we're going to talk about in a few minutes is how we differentiate from chickenpox. And this virus, the rash, tends to be much more on the palm and the sole of the feet than chickenpox does, tends to be more on the body and on the face. So that's one of the characteristics to differentiate those two. Again, we talked about they can have a prodrome of symptoms, and while they're ill, they can have fever, they can have chills, they can be pretty uncomfortable. The illness generally will be self-limited and last for 2 to 4 weeks. So self-limited being like the flu, it will go away on its own. It usually does not need treatment for mild disease, which most cases are. And the differential diagnosis has been stated. It can be things like syphilis, it can be chancroid, herpes, chickenpox, or shingles. This is a diagram that shows some of the different types of rashes that you can see. And generally, they're usually a fairly small number, but it's shown by the picture in the middle of the back of that gentleman's chest. You can see that they can also be diffuse. They are of different types. The singular one on the right is the most common one where it starts. So it's full of clear fluid, looking like a chickenpox type vesicle. And then it develops into a papular and/or a pustule where it looks like there's more purulent material in it, and then becomes debilitated, and then that little is where it resolves. The other characteristic thing about this rash with monkeypox compared to chickenpox is that all of the lesions are at the same stage throughout. So all of those lesions on that first back will be the same. There'll either be a vesicle, there'll be a papule, there'll be debilitated, or they'll resolve, as compared to chickenpox where you see different stages of it throughout the illness. So that's another key to dealing with monkeypox. The classic disseminated disease was the one in Central and Western Africa, which was clade 1. It was in young children. Often they had animal contact. It was often, in general, a centrifugal distribution, so it was over their entire body, but again, did involve the palms and the soles of the feet. It is an infectious process until the lesions are resolved, like with other pox-type illnesses such as chickenpox. So the person can continue to shed the virus until the lesions are all resolved. And perhaps they can even do that longer as far as either through semen or through stool. And then we talked about all the lesions being at the same stage or the same age. And unfortunately, as we've also said, the clade 1 had a higher mortality than the current clade 2 version. And this is just a picture again to remind us what some of the lesions will look like, and also noting again that it's on the palms pretty commonly. And that's a little closer up of what's called a pustule, which looks more like purulent material rather than of a singular lesion with clear fluid. These are some photos from Dr. Wheeler, my friend in Northern Virginia, a patient that he has seen with pustular lesion. And these are lesions that we're seeing obviously in people who have been transmitted sexually, which is the most common means of transmission currently, or with close-in contact. You can get edema of the penis and the scrotum along with the lesion. And this is an example of one of the lesions that's now healing up in the perirectal area. In the United States, we have a definition of Mpox so that we can tell exactly what stage it's at, and it's a confirmed infection if it meets the confirmatory laboratory criteria, which is monkeypox virus detected. We're going to come back to how we test for it again in a minute. It's probable infection if it meets presumptive laboratory criteria, which you test positive with a swab, testing for orthopox, which is the family of virus it's in, or if you get a blood test and the IgM blood test is positive, which usually occurs within days of onset of the illness. It's suspected if it meets other characteristics, such as having a rash with a clinical suspicion, and then at least one of the other epidemiologic criteria, such as having had close sexual contact, traveling outside the United States in an endemic area, or having been exposed to animal products, where you could also get the infection. So speaking about testing for Mpox, the usual test that's done, we talk about testing with a swab, is the orthopox DNA PCR test, polymerase chain reaction test. There is a monkeypox DNA PCR test, but it's not available commercially. So the test that is available commercially now is the first one, which is the orthopox DNA. That used to be just through the CDC and state health department, but is now available in commercial labs. So we can send that to LabCorp or Quest or other places, and they will do that for us. You can also do it not in a clinical setting, but you can do detection of the orthopox virus using immunohistochemical or electron microscopy testing methods, or you can isolate the monkeypox virus in culture. Again, none of this is done clinically or in communities. This is on a study or tertiary care level. And then you can also do serum testing, which is more straightforward and just detecting levels of anti-orthopox IgM antibody within 4 to 56 days after the onset of the rash. And that's probably the most common way it's done in outpatient settings. Just a little more specific example of how to do the Mpox testing. Again, you want to test for the non-variola, which is the non-smallpox orthopox virus. Initially, it was done through the CDC and Health Department, but now it's being done through commercial laboratories. It's available through the Health Department for eligible patients. You can use a variety of swab for it, but you want to do it dry culture media, and the results are available in about 48 hours. And as one of the previous speakers has said, you want to do on one swab, you want to do two different lesions at a time, multiple lesions to submit. So let's move on to treatment strategies for Mpox. The good news is that most of these people do very well. A small minority of people actually need to be treated. So it's usually a self-limited illness, does not have any significant sequelae, and everyone does fine. The concerns we have are people who have HIV, which has been alluded to and we'll come back to talk about, or people who are immunocompromised are at the highest risk to have serious illness. But most of these people who are in the community that have mild disease can just be treated with over-the-counter medications, oral antihistamines if they have pruritic lesions, rehydration for fluids, antiemetics if they're having nausea and vomiting, sitz baths if they have proctitis or painful lesions. And again, most people do not need antiviral treatment, and most of this really need to be encouraged and understand that this is a self-limited illness which will resolve on its own. So treatment options, as I said at the beginning, we're talking about drugs that have been used or treated for smallpox. And because this is in the same family, they're being used on a limited access or investigational drug basis for Mpox. The drug that is being recommended currently in the United States is tecovirimat, or TPOXX, which is the generic term for it. It is a expanded access in investigative new drug criteria for patients with laboratory confirmed orthopox infection or suspected infection based on known exposure and clinical manifestation. It's available in oral form as well as in IV form. So if someone who's sick in the hospital and can't take it orally can be given IV. And it can be mixed with semi-solid food for children who are small and not taking the pill. The other options for treatment were Cidofovir, which was only really FDA approved for CMV or cytomegalovirus retinitis in patients with AIDS. It's an intravenous infusion, so it's not available in oral form. Not been tested for Mpox, so we don't really know how effective that would be. It's got significant side effects, so we tend not to use it. The other treatment that can be available is Vaccinia immunoglobulin, which is given intravenously. So again, this is the smallpox vaccine virus. It's approved for treatment of smallpox in adults and pediatrics, including neonates. But it's like only for the complications due to the Vaccinia vaccination currently. So it's only approved currently for people who have had a complication with the smallpox vaccine. Then the other drug, which is being limited and used for Mpox on a limited basis, is brincyclovir or Tembexa. This is a prodrug of tecovirimat, so it's a earlier form or a later form, and that's more available in the oral form. It's only available orally, not IV. It's approved for treatment of smallpox in adults and pediatrics, including neonates. It's been used in a very limited form as far as Mpox or monkeypox, and in a limited report of 3 individuals who got the drug for monkeypox, all 3 of them developed liver function test abnormalities. The drug had to be stopped. So the adverse effects related to that drug and Cidofovir are significant, whereas fortunately the adverse effects related to tecovirimat are very small and limited. So that tends to be a drug that we use if we need to. But again, it's only available on a early access IND basis. So this is a little more specific as far as the drug goes. It's a 200 milligram tablet. It was developed for smallpox in 2018. There's an animal and PK data about how effective it would be for monkeypox, but currently there's not a lot of information about how it works for monkeypox. And we're going to come back to talking about a study that's trying to identify that. And then we talked about brincyclovir and cidofovir, which have excess toxicity, so not being used regularly. Tecovirimat works on a molecular basis where it actually blocks the reproduction of the virus. So we have entry of the virus here at the left into a human cell. The reproduction gets blocked, so the virus is not able to escape from the cell, and that's the molecular basis for its effectiveness. In order to obtain this drug, it's only approved for, it's available through the CDC and through the health department. It's only considered for people who have severe disease as defined by hemorrhagic disease, fluid lesions, sepsis, encephalitis, ocular or perioral infection, or other conditions requiring hospitalization. So it's not used in the outpatient setting when people have severe disease. Other criteria is involvement of anatomic areas that might result in serious sequelae that include scarring and strictures. This is particularly true in perianal disease, where they can get proctitis and strictures of the rectum. The area that usually do that. For people who are at high risk, people who are severely immunocompromised should get this drug because of their risk to get developing severe disease. Pediatric patients who are younger than 1 year of age, and pregnant or breastfeeding women because of the concern regarding transmission for babies, and people with a condition affecting skin integrity like this. So again, treatment with TPOXX is for adults and adolescents who are weighed between 40 and 120 kilograms. You take 3 capsules twice a day for 14 days. The clinicians and patients need to understand that there really is limited information about the effectiveness of people with monkeypox. Lack of data indicating which patient might benefit the most. We assume that people who have most or highest risk for severe disease would benefit the most, but we don't have data to support that. And then there's concern about the development of resistance that could render the drug ineffective in treated patients. We don't have any information about that either because the use has been so limited. But again, as we've said, there aren't any other really good options, and the other options we do have significant toxicity. So then the question is, what's the availability? There's information through the CDC that it can be obtained that way, through the health department. The STOMP trial has been referred to. We're going to come back to that. That is a national trial of people with monkeypox who are treated with TPOXX, and they can have mild disease between the community or in the hospital. VCU was a site for this recently in Virginia, but they're currently on hold. But Duke University and Hopkins are still sites available, and we also do it through virtual visits. The drug is also available through expanded access, which we referred to, and that's done through a process through the health department, CDC. So then going back to the idea of the STOMP trial, so as we have said, there's not any clinical data about whether this drug works or not in people with monkeypox. So this is a national clinical trial being supported by the National Institutes of Health, where they're looking at a preferred mechanism for TPOXX assets through this trial. We'd like to get people enrolled in it. It's funded by the NIH. It's a clinical trial evaluating the effect of TPOXX. But VCU was one of the sites that's currently on pause. Adults and children with Mpox who are eligible to enroll. They do not have to have severe disease or be an increased risk of severe disease. And the hope is to enroll 500 people from up to 80 clinical research sites. I looked online to see how many people have been enrolled so far, and I could not find that data. I don't know if any of those other speakers, anyone else knows. But I think they're still struggling to get the enrollment because of the number of cases being so much lower, but they're still trying. And the format is that there's two arms to it. One's an open level arm where you can get the drug if you're at risk for severe disease. And the other one is the second arm is trying to enroll the 530 adults into a 2-to-1 ratio to receive TPOXX or placebo. So that's when they're going to look at treatment versus non-treatment to see if there's significant benefit there. And then patients are not eligible or willing to enroll in STOMP can still get TPOXX through expanded access investigational drug protocol. So the drug is still available even if one participating in the trial, but we'd like to get more people enrolled. So this is the trial. This is from number on the slides that are available. So I'd like to finish up just commenting a little bit about the situation with individuals who have monkeypox, Mpox, and HIV. So this again is from my friend Dr. Wheeler in Northern Virginia. This is a patient who presented with Mpox, was not known to have HIV infection, so was found to have the HIV positive with a low CD4 count of 17. He was started on TPOXX, which was appropriate. He also had drugs. He had a positive RPR. He developed shortness of breath on day 10 of treatment. He was obviously hospitalized. He was admitted to Fairfax Hospital in Nova. He was found to have pneumocystis carinii or tracheal pneumonia during that hospitalization. He was treated for that and survived that. But during this time, he was still being treated with the TPOXX for his Mpox illness. And these are some of the pictures again emphasizing the fact that lesions are on our hands, that they're at the same stage of development. And this is how we progress as far as his lesions, despite being appropriately treated with the TPOXX medication, including involvement of his mouth and cheek and he was actually treated with IV tecovirimat because he wasn't taking orally. That was received from the Virginia Department of Health. He also was starting HIV treatment. One of the guidelines for someone who has Mpox and newly diagnosed HIV is to put them on treatment to try to improve their health status. He completed treatment for pneumocystis. So they began evolving new lesions of the TPOXX again. So we had recurrence of it despite being treated, and unfortunately eventually died from the complications of that. So as far as Mpox and HIV infection, people with HIV-associated immunosuppression or who are not virologically risk can be at increased risk for severe Mpox disease. So the primary concern of people who have low CD4 counts and are not on treatment as compared to people who are on treatment. They're still at risk, but not as great a risk. Fortunately, the medications for Mpox don't have significant interactions with antiretroviral therapy. Interestingly, the only interaction that seems to be available or known right now is with rapirivine and carbapenemir, which is on the Carbinuva treatment. So we're not using that acutely in people. But as far as standard antiretroviral therapy, not much drug-drug interaction. And then obviously there are other options for treatment that could be considered, but none of those have been shown to be clinically significant and have significant toxicity. So for people with HIV diagnosed coincident with Mpox or who are not taking antiretroviral therapy, the CDC recommends starting antiretroviral therapy as soon as possible and in consultation with an expert in HIV medicine if needed. They should have STI screening, which we've all talked about. Obviously, that gentleman not only had Mpox, HIV, also had syphilis with his positive RPR. And then virologic and immunologic characteristics of Mpox in people with advanced HIV is also in another study where they're looking at people who have HIV, Mpox to see what are the risk factors for them to develop severe disease, and that's also ongoing. I want to thank Dr. Wheeler for his allowing his slides, and thank you all for inviting me to this program and for being such a good audience. Thank you very much.